Hello, it's Dmitry again, and I'm going into a part 2 for that section from the first aid textbook for the step 1 review, the rapid review section. Now going on to the classic labs/findings. Again, the textbook that I have online is the 2017 edition, while the edition that I have in front of me that I'm reading from is going to be the 2025 edition. This is largely the same, it's very similar. However, the order is a little bit different. And so I believe the one that's the earlier version, 2017, is alphabetical. Mine is not. And so just bear that in mind. It's better to either review the textbook yourself or perhaps just listen to what I'm saying. So let's begin. Classic labs/findings. Lab/diagnostic finding. Diagnosis/disease. And then the page number gives you the page number. I'm not going to read out the page numbers for the sake of this. Colonies of Pseudomonas in lungs, increase in chloride on sweat test, increase in immunoreactive trypsinogen. What could this indicate? Cystic fibrosis, which is an autosomal recessive mutation in the CFTR gene leading to a fat-soluble vitamin deficiency and mucus plugs. Okay, well, what about low AFP on second trimester screening? That could indicate either Down syndrome or Edwards syndrome. Increased beta HCG, decreased PAPPA on first trimester screening. That's an indication of Down syndrome. Homocysteine, methylmalonic acid, and folate. Those are indicators of B12 deficiency. Okay. Antihistone antibodies indicate drug-induced lupus. Decrease in T cells, decrease in PTH, decrease in calcium, absent thymic shadow on chest x-ray. This indicates thymic aplasia, which is a 22q11 microdeletion, which is also called the George syndrome, and velocardiofacial syndrome. So basically, if you have low T cells, you can start thinking, like, why is it called a T cell? Because it's from the it's maturing in the thymus. If low PTH, what does PTH stand for? It stands for parathyroid hormone. Okay, what does that indicate? It's close to the thyroid, right? Calcium, low calcium. What does that indicate? Because it also means you have low PTH, right? Because of that. So what does that indicate overall? You probably have thymic aplasia. That could be because of the George syndrome. I guess it could be because of some other kind of situation going on. I'm sure you can remove the thymus, obviously, but that would be an indication of something like the George syndrome typically. Recurrent infections, eczema, thrombocytopenia, increased IgE and IgA, decreased normal IgG and IgM. What does that indicate? Wiskott-Aldrich syndrome, WAS gene mutation. So just be aware of that one. It's going to have the eczema, but in terms of like the actual findings, you're going to have a high IgE, okay, but high IgE and a high IgA, but your actual IgG and IgM will be either normal or low. And it's also, again, the gene name is very obvious. It's Wiskott-Aldrich syndrome, so therefore it's WAS gene. Next, giant granules in phagocytes, pancytopenia, immunodeficiency, right? It's going to be Chidiac-Higashi syndrome, LYST gene mutation, congenital failure of phagolysosome formation. So basically, what's going on with Chidiac-Higashi syndrome is because of some sort of microtubule issue, it can't actually form the phagolysosome, so the phagosome-lysosome can't fuse. And so that's kind of the gist of how Chidiac-Higashi syndrome works. And as a consequence, you just develop these gigantic granules in the phagocytes and pancytopenia, even immunodeficiency, because you really just can't use your phagosome-lysosome fusion to actually kill things that it would absorb, that it would swallow up. Aptogen sensitivity indicates sensitive, strep pneumonia, resistant, strep viridans, streptococci, strep mutans, strep sanguinis, strep mutus. So basically, if you have something that's aptogen sensitive, when they say, oh, it's aptogen sensitive, they usually are referring to strep pneumonia. And it's usually going to help you delineate that from strep viridans, which is classically aptogen resistant. Those are both alpha hemolytic streptococci, which is why you need to use aptogen to distinguish the two. Novobiocin response. If it's sensitive, it's probably staph epidermidis, okay? And if it's resistant, classically, if it's resistant, it's going to be staph saprophyticus. Again, those are two different species of Staphylococcus. Those are both coagulase negative species, so it's not like Staph aureus, which is coagulase positive. These are both negative, coagulase negative species, and so you can distinguish them based on their novobiocin sensitivity. If it's resistant, it's saprophyticus. Bacitracin response. If it's bacitracin sensitive, think strep pyogenes or group A strep. If it's bacitracin resistant, think strep agallectiae, which is group B strep. Again, those are both beta hemolytic streptococci species, and so the way you distinguish between pyogenes and agallectiae is that pyogenes is sensitive to the bacitracin, and agallectiae is resistant to it. Branching gram-positive rods with sulfur granules. Diagnostic of Actinomyces israelii. So, big one with that is that the sulfur granules are, like, again, that's a telltale sign. Now, unfortunately, on the exams, they might not just give it away like that, but sometimes they do, and you just need to know the classical presentation. Or at the very least, they might not phrase it that way, but if you know what it's about or what's going on, you can kind of maybe picture it to kind of piece it together, if you will. Hilar lymphadenopathy, peripheral granulomatous lesion in middle or lower lung lobes can calcify. What do we think? It is diagnostic of a Gone complex, which is primary TB, Mycobacterium bacilli. Again, that's a primary TB infection you might see in the middle or lower lobe, and I'm pretty sure they're going to go up into the other indications of TB, I would imagine. If not, if you have a reactivation, it might pop up in the upper lobe. But for the original primary infection, it might pop up in the middle or lower lobe, just for reference. Thumb sign on lateral neck x-ray. Epiglottitis related to Haemophilus influenzae, or H-flu. Bacteria-covered vaginal epithelial cells, positive whiff test. Those are clue cells indicating Gardnerella vaginalis. Ring-enhancing brain lesion on CT, MRI, and AIDS. Again, the important detail is it's a ring-enhancing lesion. What could it be? Toxoplasma gondii, multiple. CNS lymphoma, maybe solitary. And again, there are other kinds of things that can, there's a handful of things that can cause these sorts of brain lesions, but if it's ring-enhancing specifically, that's Toxoplasma gondii. And you can see that in the case of somebody who's immunocompromised, for example, someone who has AIDS. Dilated cardiomyopathy with apical atrophy, megacolon, megaesophagus. The indication would be Chagas disease or Trypanosoma cruzi. Atypical lymphocytes, heterophile antibodies. What do we think? Infectious mononucleosis or EBV infection. Again, if something's heterophile positive, if it's classically, that's going to be EBV, Epstein-Barr virus. Narrowing of the upper trachea and subglottis, steeple sign on X-ray. What would this indicate? CRU, parainfluenza virus. That's also going to be a paramyxovirus. It's parainfluenza virus, which we call CRU, is a virus within the family of paramyxoviruses, which are a type of RNA virus. Negative sense, I believe, negative sense single-stranded RNA virus, for be specific. Enveloped as well, if you need to know. Cytoplasmic inclusions in Purkinje cells of cerebellum and in hippocampal neurons. That should send alarm bells. Both the hippocampus pyramidal cells, I didn't say pyramidal cells, but it is pyramidal cells. Yeah. And Purkinje cells, what are we thinking? Oh, these, what do we think in these cases? Negri bodies. And what does that indicate? Rabies. So if you have these Negri bodies, again, in the cytoplasm of the Purkinje cells, and the of the cerebellum and the hippocampal neurons, specifically the pyramidal cells, that's an indication of rabies. You have rabies, not good, not fun. Concentrically laminated calcified spherules, Samoma bodies. This indicates papillary thyroid carcinoma, somatostatinoma, meningioma, mesothelioma, ovarian serous papillary cystadenocarcinoma, and prolactinoma. So not very specific, but if you have one of those, if you have Samoma bodies, it could be one of those things. So just hopefully you have some a little bit more detail than just that. Or the answer choices make it pretty clear what's going on. Boot-shaped heart on X-ray. Ooh, that's fun. Tetralogy of Fallot due to right ventricular hypertrophy. So just be aware of that. It is a boot heart presentation. Rib notching. And obviously, it's an interesting classical presentation. Of course, I don't. I'm not in favor of right ventricular hypertrophy, I suppose. But anyway, rib notching, inferior surface on X-ray. What does this indicate? Coarctation of the aorta. And why is that happening? Because basically, if your heart cannot pump blood effectively to the lower body, to the lower extremities and so forth, because the aorta is, coarcted, it has issues transporting the blood effectively, the body tries to find alternative routes to get blood to the rest of the body, and that means is through the arteries of the ribs. And so these arteries are going to be basically dilated because they're going to be full of blood because it's trying to get it through there as opposed to where it normally should be. And that eventually, in the long term, creates notching of the ribs. So it's a very interesting way in terms of how when the body has a pathology, in this case coarctation of the aorta, it tries to find a new way to maintain homeostasis, which changes the physiology of the body and creates a unique sign that allows it to diagnose what's going on in the first place. Anyway, delta wave and shortened PR interval in ECG may lead to supraventricular tachycardia. What would that indicate? Well, Wolff-Parkinson-White syndrome. Bundle of Kent bypasses the AV node. Electrical alternance. Alternating amplitude of R waves on ECG. This indicates cardiac tamponade or tamponade. I want to say tamponade, even though that's not really accurate because I'd say lemonade, I don't say lemonade, but whatever. It's pronounced tamponade. Granuloma with giant cells after pharyngeal infection. Aschoff bodies. Rheumatic fever. Yeah, so Aschoff bodies, rheumatic fever will give you Aschoff bodies, and those are going to present as a granuloma with giant cells after a pharyngeal infection. Very important pharyngeal infection in that context. And when we say rheumatic fever, what do we even really mean? What does that? Oh, you have a rheumatic fever. What does that indicate? It is a consequence of having usually something like, classically that's going to be strep pyogenes infection. So you have a group A strep infection, and so you can get something like rheumatic fever. I'm just going to say classically because I don't want to say that this is the only reason why you get something. I also don't want to say there's multiple reasons, that there isn't any other reasons for something. I'm just going to say classically it's this or classically it's that, just to kind of I'm going to be a little bit legalistic in the sense of the matter. I'm going to kind of cover my tracks, I guess you could say. Increased levels of fibrin degradation products or D-dimers. So what does elevated D-dimers indicate to you? Well, it could be a DVT or DIC. Basically what's going on is that when you have this sort of clotting issue, your body, let's say you have a lot of clotting going on right now for some sort of pathology, like you have DIC, for example, or I guess it could be a DVT, which is another, like a particular clot. Your body's going to start trying to break that clot down. And at that point, there's actually an actual fibrin, clot, plug, whatever you want to say at the time. And it's normally formed, fully formed, right? And so if you're trying to break it down, you're going to form these D-dimer products. And so in contrast, if you have a fibrinolytic condition where you're just breaking down fibrin without any clotting developing in the first place, you will have these other clotting remnants, right? Because you're breaking down fibrin, but you will not have D dimers because D dimers are a consequence specifically of clotting happening in the first place. So it helps you distinguish between a fibrinolytic condition where there's no clotting going on versus an actual clotting problem going on like DIC or DVT. Empty appearing nuclei with central clearing in thyroid cells. That's what we call orphan anti-eyes, which are indication of papillary thyroid carcinoma. Brown tumor of bone. This indicates hyperparathyroidism or osteitis fibrosa cystica, deposited hemosiderin from hemorrhages causing brown color. Hypertension, hypokalemia, metabolic alkalosis, increased aldosterone, and decreased renin. What are we thinking? Well, that's an indication of primary hyperaldosteronism, also called Conn syndrome. That's CONN syndrome. Mucin-filled cell with peripheral nucleus. This indicates, this is a signet ring cell, which indicates diffuse gastric carcinoma. Anti-transglutaminase / anti-deamidated gliadin / anti-endomysial antibodies. Well, that's a mouthful. What does that indicate? Celiac disease, diarrhea, and weight loss would be associated with that. So if you have, I have diarrhea, I'm losing weight, etc., and they look a little bit further with some labs, and they say, you have anti-transglutaminase and anti-deamidated gliadin and anti-endomysial antibodies. What does that indicate? If you have some of that going on, you'd probably be celiac disease. Narrowing of the bowel lumen on small bowel follow-through. This is called string sign, which is an indication of Crohn's disease. And just for reference, this particular section in the book is going to be one of the longer sections of this particular chapter, but the latter, I think it was 3, 4, 5, and 6, I think. The latter sections overall are shorter, but this one is a little bit longer. And honestly, it would make sense because it is more important. Lead pipe appearance of colon on imaging. This indicates ulcerative colitis, which is going to have a loss of Haustra. Thousands of polyps on colonoscopy after puberty. This indicates familial adenomatous polyposis, autosomal dominant APC gene mutation. Apple core lesion on barium enema X-ray. This would indicate colorectal cancer, usually left-sided. Nutmeg mottled appearance of liver. Chronic passive congestion of liver due to right heart failure, Budd-Chiari syndrome. So they say chronic passive congestion of liver due to right heart failure, Budd-Chiari syndrome. So I would imagine in the context of the first one thing we're talking about, which is the congestion, if you have right heart failure, let's say, for example, blood's backing up from the heart. Usually when we think about right heart failure, we're thinking about the JVD. We're thinking about blood pulling up, and so you can see in the neck, you can see that JVD. Now, you also have potentially, in right heart failure, the blood is backing up back to the heart, right? Or sorry, from the heart back into the liver, and that can cause this sort of congestion, and that can create this nutmeg mottled appearance of the liver. Eosinophil, but typically my understanding would be that you'd probably see JVD before you start seeing real serious liver damage because of some sort of heart issue. And I'm not mistaken, what do you technically call that? Let me just check that for a moment. Cardiac. Yeah, okay, good. Well, not good for the person, but good for me figuring out what it is. Severe liver scarring and damage caused by long-term right-side heart. Yeah, so I would call that, based on what I'm just reading right here, it would be called cardiac cirrhosis. Because I was thinking, isn't it called like a type of cirrhosis or something? Yes, it is. It's cardiac cirrhosis. So it's very on the nose, essentially. Eosinophilic cytoplasmic inclusion of damaged keratin within hepatocyte. This is called a Mallory body, and that's an indication of alcoholic hepatitis. Again, this is actually phrased very well, because they're not going to say, the patient has a Mallory body. What could this indicate? And they say, of course, it's alcoholic hepatitis. Of course it would be. they might just tell you like something like, oh, it's an eosinophilic cytoplasmic inclusion of the damaged keratin within the hepatocyte. And it's like, that's sort of, it feels like a little bit of a word salad for just saying Mallory body. It's a little bit more to the point. But the whole point is that you're supposed to know what a Mallory body is in the first place and not simply know the word Mallory body. Fatty infiltration of hepatocytes, leading to cellular ballooning, eventual necrosis. What could that be? Fatty liver disease, associated with alcohol use or metabolic syndrome. Anti-smooth muscle antibodies, ASMAs, anti-liver/kidney microsomal 1, anti-LKM1 antibodies. Those indicate autoimmune hepatitis. Anti-mitochondrial antibodies, AMAs. That indicates primary biliary cholangitis, female, cholestasis, portal hypertension. Okay. Next one. Low serum ceruloplasmin. What could that indicate? Wilson's disease. Remember, Wilson's disease, those are with the Kaiser-Fleischer rings in the eyes. That's the disease with the copper excess. It is going to be showing a low serum ceruloplasmin. Next, migratory thrombophlebitis leading to migrating DVTs and vasculitis. What could that indicate? Trousseau syndrome, pancreatic adenocarcinoma. Next, basophilic stippling of RBCs, basophilic ribosomal precipitates. That indicates sideroblastic anemia, thalassemias. Next, basophilic nuclear remnants in RBCs. That can indicate Howell-Jolly bodies due to splenectomy or non-functional spleen. And the idea behind this is that because the spleen is normally filtering RBCs, and so anything that kind of looks a little bit weird, in the RBCs, it will remove those. So if it can't do that because it doesn't function anymore, you're just like these sort of weird-looking RBCs in the body, including these Howell-Jolly bodies, right? They just, because your spleen doesn't work, it can't filter stuff out effectively, and so you just have these sorts of anomalous-looking basophilic nuclear remnants just hanging out in these RBCs, right? Or I might be a little bit mistaken. I think the spleen helps remove them. I mean, in the sense that the RBCs are preserved. They just I want to confirm how bodies removed. It says how Jolly bodies are naturally removed by the spleen. The spleen's macrophages extract these inclusions without destroying the red blood cell itself, a process called pitting. Okay, so you might not need to know the process per se in the context of this the Step 1 exam, but just for reference, it doesn't have to destroy the RBCs. It just has to remove the Howell-Jolly bodies from them in a process called pitting done by macrophages. Just as a fun FYI. Of course, you would probably find that very entertaining. Now, next would be hypochromic microcytic anemia. It says here it could be iron deficiency anemia. That's like the most obvious one, but it could also be lead poisoning, true. Thalassemia, fetal hemoglobin sometimes present, and sideroblastic anemia. So those are all possibilities, and they're not totally, like sideroblastic anemia, it is connected to the iron deficiency thing. It's not because you're not taking in enough iron or that you're not absorbing enough iron per se. It's more about your body is sequestering iron. So the mechanism's kind of interrelated as far as I'm aware. But those are typically when somebody says, oh, iron deficiency anemia, think about iron deficiency. Sorry, when you think about microcytic anemia, think about iron deficiency anemia, but it doesn't necessarily mean it could be lead poisoning is real, right? That's obviously a problem. It could be an anemia of chronic disease, where your body, and that's what I'm thinking about, is that your body is sequestering the iron, and that causes you to have sort of the situation where you might have a sort of a normochromic normocytic anemia, but then it slowly transitions into a microcytic anemia later on. Again, because the mechanism is similar to how iron anemia works, because it's sequestering the iron. It could be sideroblastic anemia, it could be thalassemia, it could be some of these other kinds of things. Let me just confirm sideroblastic anemia mechanism. Yeah. So, basically, even sideroblastic anemia, I was saying before, well, I was trying to communicate something about the fact that if you have sequestering of iron, but it says here, sideroblastic anemia is characterized by a failure to synthesize hemoglobin because of impaired iron utilization in red blood cell precursors. Yeah, okay, it says iron gets trapped in the mitochondria or developing erythroblast, wrapping around the nucleus to form a ring sideroblast. It goes back into, again, this is a little bit better explanation than I was giving. This is more accurate than what I was saying. But the principle lies that it's an iron issue, not because you're not absorbing the iron in that context, but because of how it's not being utilized correctly, or in a normative way, I should say. Hair on end or crew cut appearance on the skull X-ray. That indicates beta thalassemia or sickle cell anemia because of marrow expansion. How does that work? Because the body says, oh, we don't have enough red blood cells. We need to start making more red blood cells. And so it starts utilizing the skull. Yes, it starts utilizing the skull, among other bones, to start really ramping up the number of RBCs they're producing because they're just losing them, essentially. There's not enough around because you have an anemia, right? So your body says, oh, we need more red blood cells, and so it starts making them in places that you otherwise would not typically see. Hence the crew cut appearance of the skull. Hypersegmented neutrophils. Megaloblastic anemia, vitamin B12 deficiency, hypersegmented neutrophils. This would indicate megaloblastic anemia, which is a vitamin B12 deficiency, neurologic symptoms, folate deficiency, no neurologic symptoms. So basically, when you think to yourself, oh, let's say I have megaloblastic anemia, I have these hypersegmented neutrophils, I'm thinking, oh, it's either B12 deficiency or folate deficiency. So what are the differences? How do I distinguish between the two? Well, a lot of the time, if you have a B12 deficiency, you also have neurological issues as a consequence. You could have, I think you'd have SCD, right? Subacute combined degeneration, is that right? B12 SCD. Yes, that's correct. Okay, just want to confirm. But with folate deficiency, you wouldn't have that, so it's not the same presentation clinically. So just keep that in mind. Anti-GP2B/3A antibodies. They indicate immune thrombocytopenia. Giant B cells featuring bilobed nuclei with prominent inclusions, also called owl eyes. What would that indicate? Reed-Sternberg cells, which indicates Hodgkin's lymphoma. Sheets of lymphocytes with interspersed tingible body macrophages, also called a starry sky histology. What would this indicate? Burkitt lymphoma, T814 CMYC activation associated with EBV, starry sky made up of malignant cells. And let me just find that because the way they say T8 8:14. Now, another thing too with Burkitt lymphoma is that it's associated with what happened right here. Where's EBV? It says sheets of. Let's see if we can go to sheets of right here on this one. This one, here we go. I think it's right here. Sheets of. Does it say it? Yeah, right here. It says here, Burkitt lymphoma, right here. So T8:14, etc. So you can see that right now with me. Now, the thing with Burkitt lymphoma also that it's associated with children in North Africa. And it's also associated with something matters with the jaw. So think when you start talking about the jaw and maybe North African children or something like that, you might want to start thinking about Burkitt lymphoma, which is caused by EBV. EBV also causes Hodgkin lymphoma, which was talked about before. It also causes non-Hodgkin lymphoma. So it just really is a bundle of fun, you know. I'm not sure if anybody really asked themselves, I really want this virus to cause more than one kind of cancer, So, but it causes 3 different kinds of cancer. So, it's a lot. So, let's continue. Lytic punched out bone lesions on X-ray. What would this indicate? Multiple myeloma. Next, monoclonal spike on serum protein electrophoresis. This indicates multiple myeloma, usually IgG or IgA, or Waldenstrom, or I assume that's called Waldenstrom because it's not English, it's German, with a little umlaut, or maybe it might be Swedish. Who knows? I don't really know. But Waldenstrom, macroglobulinemia, globulinemia, IgM, monoclonal gammopathy of undetermined significance. So again, if you have monoclonal spike on serum protein electrophoresis, that can indicate multiple myeloma, either an IgG or an IgA, Waldenstrom macroglobulinemia, IgM, monoclonal gammopathy of undetermined significance. So it could be one of those four things, or one of those three things, I guess you would say. Stacks of RBCs, rouleau formation, increased ESR, multiple myeloma. So again, if you have a stacks of RBCs, it's probably a rouleau formation indicating increased ESR and multiple myeloma. Now next, myeloperoxidase positive, cytoplasmic inclusions in myeloblasts, increasing circulating myeloblasts. What would that indicate? Our rods, APL. White blood cells that look smudged. What would that indicate? CLL. And let me just confirm, I want to make sure, because I feel like I need to do my due diligence on this stuff. Smudged, CLL is a, what does it say? Chronic lymphocytic leukemia. I didn't want to necessarily just say, oh yeah, CLL, of course everybody knows what CLL stands for. It actually refers to chronic, sorry, let me go back to it. It does stand for, in fact, chronic lymphocytic leukemia. So in the case of those smudged white blood cells. Just bear that in mind. Now, tennis racket shaped cytoplasmic organelles on EM in Langerhans cells. Those would indicate a Burbeck granule, Langerhans cell histiocytosis. Okay, next page. Let me see if I can get a little bit of a drink or something. Now bear in mind this video should not be as long as the previous video on this chapter. This section I think is like 12 pages and I covered maybe 19 pages last time. Not exactly sure, but something like that. So it should be theoretically somewhat shorter. Doesn't mean it's going to be short, it just means comparatively, you know. Next. Lab diagnostic finding, diagnosis disease. Okay. Soap bubble in femur or tibia on x-ray. This would indicate giant cell tumor of bone, generally benign. Elevated periosteum creating a Codman triangle or sunburst pattern on x-ray. What would this indicate? Osteosarcoma, osteogenic sarcoma. Next, onion skin periosteal reaction. So onion skin periosteal reaction, what would that indicate? Ewing, Ewing, sounds like ooable. Ewing sarcoma, malignant small blue cell tumor. Let me just spell that out for you. Ewing, Ewing sarcoma, malignant small blue cell tumor. IgM antibodies that target IgG Fc region, anticyclic citrulinated peptide antibodies. This would indicate rheumatoid arthritis, systemic inflammation, joint pannus, Boutonniere, and swan neck deformities. Okay, next. Needle-shaped negative birefringent crystals. Now that's important. It says needle-shaped negative birefringent crystals. What are we thinking of this one? Well, it'd be gout. Monosodium urate crystals. Okay. What about if I have increased uric acid levels. What would that maybe an indication of? Well, it could be key gout, right? Lesch-Nyhan syndrome, I guess. Lesch-Nyhan syndrome, tumor lysis syndrome, loop and thiazide diuretics. All that's correct. Now, these are not necessarily mutually exclusive, and in fact, gout is more of a consequence of high uric acid levels, while the other ones are usually a cause. So, Lesch-Nyhan syndrome causes high uric acid levels, but then high uric acid levels then caused gout, for example. All those other things I mentioned, Lesch-Nyhan syndrome, tumor lysis syndrome, loop and thiazide diuretics, those all increase uric acid levels, and that can cause gout. So, now, of course, that sign itself can indicate both of those things, right? But one of those things is the cause, and the other one is a consequence, basically. Rhomboid, positive birefringent crystals. What would that indicate? Well, that would indicate pseudogout, which is a calcium pyrophosphate dihydrate crystal, which is different from the gout, I guess you could say, which is a monosodium urate crystal. So it's monosodium urate crystal, urate, important part, that's gout. If we're talking about a calcium pyrophosphate crystal, calcium pyrophosphate dihydrate crystal, it is going to be a pseudogout. And again, pseudogout is a rhomboid, positive birefringent presentation. Bamboo spine, vertebral fusion on X-ray. What are we thinking? Ankylosing spondylitis, chronic inflammatory arthritis associated with HLA-B27. Very nasty stuff. Anti-nuclear, anti-Smith, anti-dsDNA, anti-phospholipid antibodies. What are we thinking with that? Think about SLE, so systemic lupus erythematosus, I believe it is. Just to be sure, it's lupus, just for reference, it's lupus. It is systemic lupus erythematosus, so just wanted to double check. And that's what it is currently. So lupus, if you have those kinds of, you have anti-nuclear, anti-Smith, anti-dsDNA, anti-phospholipid antibodies, that is lupus. So SLE, type 3, and to a lesser degree, type 2 hypersensitivity. Anti-neutrophil cytoplasmic antibodies, or ANCAs. What do those indicate? Microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, and primary sclerosing cholangitis, MPO ANCA/P ANCA, granulomatosis with polyangiitis, PR3 ANCA/C ANCA. So there's a little bit of a difference between those two things. So you have MPO ANCA/P ANCA, which is with primary sclerosing cholangitis, and then you also have PR3 ANCA/C ANCA, which is going to be granulomatosis with polyangiitis. So just bear that difference in mind. Anti-SEL70, anti-DNA topoisomerase, and anti-RNA polymerase 3 antibodies. This indicates diffuse scleroderma. Scleroderma. And it's in the name. It says anti-SEL70. So what are we thinking of anti-SEL70, SEL scleroderma? So that's fair enough. Anti-DNA topoisomerase 1 and anti-RNA polymerase 3 antibodies. Okay, sure. Anti-centromere antibodies. What are we thinking about with anti-centromere antibodies? We're thinking limited scleroderma, Crest syndrome. Okay. Next, anti-desmoglein 3 plus or minus 1 anti-desmosome antibodies. What would it be? Pemphigus vulgaris. Next, anti-hemidesmosome antibodies. This indicates bolus pemphigoid. And just bear in mind, okay, if it's this thing, it's bolus. If it's this thing, it's pemphigus vulgaris. If it's this thing, it's Crest syndrome. Just be aware of what antibodies are going to what. Because these are maybe like you consider like a family of pathologies, but they're technically different in terms of what they're attacking and what's the name of the disease, of course. Keratin pearls on skin biopsy. This would indicate squamous cell carcinoma. Increased AFP in maternal serum. This would indicate Dating error, which is possible, might not be a disease. It could be just a dating error when they dated things. Open neural tube defect, and an NTD, right? That's obviously a disease, a serious one at that. And so, it's not if you have a high AFP in terms of your results, it doesn't necessarily mean there's a disease going on, but it could very well be a serious disease. So just keep that in mind. Bloody or yellow CSF on lumbar puncture. Xanthochromia due to subarachnoid hemorrhage. Next, loss of dopaminergic pigmented neurons in substantia nigra. What would this indicate? Parkinson's disease. Again, remember, Parkinson's disease is an attack of the dopamine producing or dopamine releasing cells of the substantia nigra. And I think specifically the pars compacta, if I'm not mistaken. I know this seems a little bit silly because it's like, well, does it matter if it's a pars compacta versus? Yeah, I want to check what part of the substantia. Yeah, it's going to be the pars compacta. It is pars compacta. Okay. Now, where were we? Intracellular eosinophilic inclusion in neuron. This would indicate, well, this is a Lewy body, which is composed of an alpha-synuclein, Parkinson's disease, and Lewy body dementia. So, basically, if you have the intracellular eosinophilic inclusion in a neuron, that is a Lewy body. That could be a Lewy body dementia, or that could be a Parkinson's disease situation. Now, extracellular amyloid deposition in gray matter of the brain. This would indicate senile plaques, as you would find in Alzheimer's disease. Next, hyperphosphorylated tau protein aggregates in neurons. What would that indicate? Neurofibrillary tangles, that's what those are, and this would be an indication of Alzheimer's disease, and PIC bodies, which are indication of frontotemporal dementia. And just bear in mind, sometimes you'll see a lot of overlap in terms of the presentation between PIC's disease and Alzheimer's disease, but the actual sort of process of how it develops is a little bit different. Typically with frontotemporal dementia, the name kind of gives it away. There's a frontotemporal dementia. And so you might have a personality change earlier on in frontotemporal dementia in a way that you really wouldn't have necessarily until much later in Alzheimer's disease. So just bear that in mind. But you would see these neurofibrillary tangles in Alzheimer's disease, and you have quote-unquote PIC bodies in the frontotemporal dementia. But again, they look similar. And those are tau protein aggregates for reference in the neurons. Now next, pseudopalisading pleomorphic tumor cells on brain biopsy. So when you hear pseudopalisading, what are we thinking here with this? Glioblastoma. It's a glioblastoma. Small blue cells surrounding central area of neuropil. Neuropil. Is that correct? Neuropil? Am I losing my mind? Is that on me? Yes, that is on me. It is a neuropil. So that would be Neuropil, neuropil. Small blue cells surrounding the central area of the neuropil. These would be homocyte rosettes, classical term, which indicates a neuroblastoma or a medulloblastoma. RBC casts in urine. So this is like it's not that you have like a lot of blood in your urine and they can really see it, but there's RBC casts in your urine. There's something going on. What would this indicate? Glomerulonephritis, hypertensive emergency. Very true. White blood cell casts in urine. This would indicate acute pyelonephritis, transplant rejection, tubulointerstitial inflammation. So just think about, like, why would you have white blood cells in your urine? It's because some sort of infectious or inflammatory process is going on. And so just think about, okay, what kinds of processes could that be, right? Acute pyelonephritis. Transplant rejection, of course, right? Tubulointerstitial inflammation, right? So just think about what it could be, just from a logical perspective. Granular, muddy brown casts in urine. What are we thinking? Acute tubular necrosis. That is to say, ischemia or toxic injury. Waxy casts with very low urine flow. What are we thinking? End-stage renal disease or chronic kidney disease. Or I should say end-stage renal disease / chronic kidney disease. Wow, this is longer than I hoped, but it is what it is, Lumpy, bumpy appearance of glomeruli on immunofluorescence. What are we thinking? Infection-related glomerulonephritis due to IgG, IgM, and C3 deposition. Next, antiglomerular basement membrane antibodies, linear appearance of IgG deposition on glomerular and alveolar basement membranes. What are we thinking? Goodpasture syndrome, hematuria, hemoptysis, right? So you will see hematuria, right, blood in the urine, and hemoptysis, blood in coughing it up, in Goodpasture syndrome. Necrotizing vasculitis, lungs, and necrotizing glomerulonephritis. What do we think? Granulomatosis with polyangiitis, PR3 onca/C onca, and Goodpasture syndrome, antibasement membrane antibodies. Next, cellular crescents in Bowman space on light microscopy. Rapidly progressive crescentic glomerulonephritis. This is what we're thinking about. Wire loop glomerular capillary on light microscopy. What would it be? It indicates diffuse proliferative glomerulonephritis, usually seen with lupus. Next, tram track appearance of capillary loops of glomerular basement membranes on light microscopy. What would this indicate? Membranoproliferative glomerulonephritis. Next, effacement of podocyte foot processes on EM. What do we think? Minimal change disease, child with nephrotic syndrome, focal segmental glomerular sclerosis, which is FSGS, nephrotic syndrome, more common in black individuals. So it could be minimal change disease or FSGS when you have that effacement of the podocyte foot processes. Next, spike and dome appearance on subepithelial deposits indicates membranous nephropathy, nephrotic syndrome. Eosinophilic nodular glomerular sclerosis, Kimmel-Steele-Wilson lesions, diabetic glomerular nephropathy. Next, thyroid-like appearance of kidney. What does this indicate? Chronic pyelonephritis. Very weird. It looks like a thyroid. What is it? Chronic pyelonephritis. Increase in HCG, that is a human chorionic gonadotropin. What do we think with that? Multifetal gestation, that's the hopeful situation. You have twins or something, Hydatidiform mole, not so great. Choriocarcinoma, again, not so grand. Dysgerminoma, or Down syndrome. So it could be a lot of different things. Ideally, it's not pathology, like, we just have twins or something, but it could be a lot of other things, of course, as well. Dysplastic squamous cervical cells with racinoid nuclei and paranuclear halo. What do we think? Coilocytes, HPV infection, predisposes to cervical cancer. Sheets of uniform fried egg cells, increase in HCG, increase in LDH. Dysgerminoma. Next, Schiller-Duval bodies resemble glomeruli, increase in AFP. This indicates yolk sac tumor. Next, disarrayed granulosa cells arranged around collections of eosinophilic fluid. What does this indicate? Call-Exner bodies, granulosa cell tumor of the ovary. Chocolate cyst in ovary. What are we thinking? Endometriosis. Mammary gland, blue domed simple cyst. So what do we think in that context? We're thinking fibrocystic change of the breast. Okay, sure. Eosinophilic cytoplasmic inclusions in Leydig cells. What do we think? Reinke crystals, or Reinke, R-E-I-N-K-E crystals. Leydig cell tumor. Next, interdigitating layers of pink and red in arterial thrombi. These are called lines of Zahn, Z-A-H-N. Layers of platelets and RBCs seen only in thrombi formed before death. So that's an indication to you that if, because there's all sorts of processes, this is actually goes into when I was studying osteology, the bones, and they talk about the difference between like pre-mortem, perimortem, and post-mortem. So if you have certain kinds of, as an analogy, there might be similar presentation to something that was actually around the time of their death versus something that happened after they died. So you might say, oh, this bone was broken. They must have had an accident when they died. It could have been the bone was broken after they died and they were already dead. And so in the context of what lines of Zahn are hopefully indicating to us is that this is a thing that was going on when they were dying, probably, or sometime before that they technically died, rather than something that happened as a consequence of their body simply degenerating and decaying as a consequence of death. So it's a perimortem rather than it's supposed to help you distinguish between the perimortem situation rather than a post-mortem condition. Next, eosinophilic, hexagonal, double-pointed crystals in bronchial secretions. This would indicate, or this is, a Charcot-Leyden crystal, which indicates asthma. Next, whorled mucus plugs formed from shed bronchial epithelium. What do we think? Kirschmann spirals, asthma. Kirschmann spelled Curschmann, spiral. Next, honeycomb appearance of the lungs on chest X-ray or CT. What do we think? Idiopathic pulmonary fibrosis. Next, golden brown fusiform rods resembling dumbbells in alveolar sputum visualized with Prussian blue stain. This would indicate asbestos, ferruginous bodies. Or ferruginous, F-E-R-R-U-G-I-N-O-U-S, ferruginous bodies. And I would assume, because the word ferruginous is in there, and they're talking about the word fer in this case might refer to ferrum, which refers to iron in Latin. I would assume because the word ferru is in there. And we're talking about Prussian blue, we think about that in the context of iron, right? If you know about something that happened 75 years ago, and you were a fan of the era, perhaps, and just the history involved in that kind of stuff. Prussian blue is associated with iron, so yeah, basically that's what that's about. Let me just confirm. I want to confirm something with this. Asbestos, ferruginous bodies. Well, it says a golden brown, beaded, or dumbbell-shaped microscopic structure that forms in the lungs. It says, It says it's created when immune cells, macrophages, attempt to engulf inhaled, indigestible, foreign fibers like asbestos and other silicates and coat them in an iron-rich protein matrix. So I said, again, it's the iron that we're talking about here. Okay? Next, bronchogenic apical lung tumor on imaging. This would be indication of Pancoast tumor, superior sulcus tumor, Pancoast superior sulcus tumor, which can compress the cervical sympathetic chain, leading to Horner syndrome. And of course, you think about the symptoms of Horner syndrome. When you have that compression of the sympathetic chain, what would that cause? Just be aware of that. We'll take a little bit of a break again. Okay. And that actually concludes that section, the lab section on classical lab bindings. Now we're really ongoing to the key association section. And that will proceed forth after that to the equation section, and then after that, easily confused medications. So not all that much after this point, although together they are, a decent bit of reading still. Technically, I think we have more reading ahead of us than behind us, so for this particular video. Key associations. Disease finding. Let me just go to the page, because it's in this book as well, in this older PDF as well. I think so, right? Is it? Is it not? Oh, wow, interesting. We have a different, here we go. They have it says here, what does it say? Classic/relevant treatments. I don't have that section in my textbook. I guess I can read this one as well if I wanted to. At some point they said to themselves, oh, we don't really need this anymore. I don't know why. Key associations. So let's get to it. But again, my textbook is different, so my order will be different. Disease finding, most common important association. Mitochondrial inheritance. Disease occurs in all offspring of affected females, maternal inheritance pattern, heteroplasmy. So basically, for people who might not be aware, usually, when we talk about DNA, most DNA is autosomal. And so you get 50% from your father and 50% from your mother. However, if you're male, right, if you're a man, that kind of thing, you have a Y chromosome, and as a consequence of that, you will get that from your father because only males have Y chromosomes and not the other way around. Women do not have Y chromosomes in principle, right? So they will not have that. You will have basically an identical, if you're a man, you will have almost an identical Y chromosome to your father and his father before him, et cetera, et cetera, et cetera. It's a very interesting phenomenon. However, there's also a similar interesting phenomenon with mitochondrial DNA. And so you will inherit basically mitochondria, whether you're male or female, you will inherit the mitochondria from your mother. They'll be identical to her mitochondria basically, and it'll be identical to her mother's mitochondria, et cetera, throughout a maternal lineage. And so it's very useful in the context of, you could do things like testing for relationships. Obviously, if you have a different Y chromosome than your father, then I guess he's not the real father, that kind of thing, And it helps with genealogical considerations as well. Obviously, the maternal thing is usually kind of brushed aside, but it is relevant. And that is how mitochondrial DNA works. It is a maternal inheritance, a purely maternal inheritance with no input from the father. And if you're a man and you have mitochondrial DNA, obviously you do, you will not pass that on to any of your children, not your male children, not your female children, not your daughters, not your sons, because you are the father, right? Just for reference. It's an interesting phenomenon. Intellectual disability, Down syndrome, sporadic, Fragile X syndrome, inherited. Fair enough. And those are like pathological indications of intellectual disability. There's plenty of other reasons that somebody could be intellectually disabled or challenged, not just those two things. Environmental, other genetic conditions, etc. Vitamin deficiency, USA. What are we thinking? Folate, pregnant women are at increased risk. Body stores only a 3 to 4 month supply. That's why multivitamins are, that's why I should say a prenatal multivitamin is important. Lysosomal storage disease, Gaucher's disease. I'm pronouncing that Gaucher, Gaucher, or I would pronounce it Gaucher, but I guess you could call it Gaucher, whatever. HLA-DR3, type 1 DM, SLE, Graves' disease, Hashimoto thyroiditis, Addison's disease. HLA-DR4, rheumatoid arthritis, type 1 DM, Addison's disease. Bacteria associated with gastritis, peptic ulcer disease, and gastric malignancies, that is to say adenocarcinoma or multoma. What are we thinking? H. pylori. H. pylori, very, very important. That's Helicobacter pylori. Opportunistic respiratory infection and AIDS. What do we think? Pneumocystic girovecci. So that'd be PJP, or pneumocystic girovecci. I pronounce it girovecci like it's Italian. I don't know if it is. I guess it's Latin technically, so it's girovecchi. In English, you might say girovecii, vecii, whatever. It is pneumocystis, Jirovecii, girovecci. I would say girovecci. PJP, because the pneumonia, it causes pneumonia. Viral encephalitis affecting a temporal lobe. What are we thinking? HSV1. HSV1 is the number one cause of temporal lobe encephalitis. And it's super weird too, because a lot of people have HSV1. A lot of people have oral herpes. It's very, very common, and it can cause a pretty serious condition. Next, viral infection secondary to blood transfusion. What do we think? Hepatitis C. Hepatitis C, as in the C as in citrus, C as in whatever, cart or whatever. Food poisoning, exotoxin mediated. What do we think? Staph aureus or Bacillus cereus. Bacillus cereus, we think about when we talk about reheated rice, think Bacillus cereus. Healthcare associated pneumonia. So this is like a nosocomial pneumonia. What do we think? Staph aureus, Pseudomonas, other enteric gram-negative rods. Okay, next. Bacterial meningitis from 0 to 6 months old. Think group B streptococcus, which is another way of saying Strep agallectiae, E. coli, and Listeria. Now, bacterial meningitis greater than 6 months old. Think group B, think strep pneumonia. So it's greater than 6 months, think strep pneumonia. If it's less than 6 months, think Strep agallectiae, E. coli, Listeria. Now, osteomyelitis. Think Staph aureus, which is the most common overall. When you say osteomyelitis and sickle cell disease, think about Salmonella and Staph aureus. When we're talking about osteomyelitis with injection drug use, think Staph aureus, but also Pseudomonas and Candida. UTIs, think E. coli and Staphylococcus saprophyticus. E. coli is the number one cause of UTIs, and saprophyticus is number 2. Bacterial STI, think C. trichomonas, D through K. So this is an important detail. It's chlamydia trachomonas. I think you probably heard of that first term, chlamydia, before. Chlamydia trachomonas, D through K. That's D as in dog, K as in Krypton, I don't know. Those are going to be the ones that cause bacterial STI. Think about that. Pelvic inflammatory disease, PID. Think about C. chlamydia trachomonas, subacute, or Neisseria gonorrhea for acute. Metastases to the bone. Think prostate, breast as the big ones. Then think maybe lung, I guess, and then maybe kidney or colon. But really, really think about, when you talk about metastases to the bone, think prostate or breast. For metastasis to the liver, think about colon, then breast. Somewhere down the line, think pancreas, okay, lung, maybe, and prostate. But the big ones really do think about colon and maybe breast. For metastases to the brain, what do we think? Think about the lung, maybe the breast, and then that farther down the line, maybe melanoma, maybe colon, maybe prostate. But the big ones for metastases to the brain, think about lung or breast origin. S3 heart sound. What do we think about that S3 heart sound? Increased ventricular filling pressures, that is to say MR, AR, HF, thyrotoxicosis, common and dilated ventricles. And I want to say that again, S3 heart sound, think about increased ventricular filling from, they say MR, I would assume that's mitral regurgitation, AR, aortic regurgitation, HF, I think it's just heart failure, I would not be mistaken, thyrotoxicosis as well. And these are common in dilated ventricles when you have S3. What about S4, Grant? What? Granted that those things are the case for S3, what about S4? What about S4? Well, in S4's case, it's a little bit different. You have a stiff/hypertrophic ventricle, aortic stenosis, restrictive cardiomyopathy. So again, granted, we're talking about S3, it's going to be MR, AR, HF, thyrotoxicosis. Okay, but S4 is going to be a little bit different. It's not dilated. It's a stiff, hypertrophic ventricle with aortic stenosis, restrictive cardiomyopathy. So it's a little bit of a different cause for it, right? So if it's S3, you start thinking about dilated ventricles. When it's S4, okay, in that case, you got to start thinking about a stiff hypertrophic ventricle. This is a little bit different. In that case, we said we have aortic stenosis and restrictive cardiomyopathy as possibilities related to that. Hollow systolic murmur. Hollow systolic, important. It's across the entirety of it's hollow systolic. Hollow referring to like the whole, and systolic referring to, well, across systole. I want to make sure that I'm saying that correctly. Hollow systolic meaning, yeah, also means pansystolic, so across the entire thing. I didn't want to make sure that I confused my etymologies here. So holosystolic or pansystolic murmur, we're thinking VSD, which is ventricular septal defect for reference, VSD, tricuspid regurgitation, and mitral regurgitation. I definitely need to review this again as well. Because I'm familiar with this stuff to some degree, right? I've been over this kind of stuff before, but it is key, it's key stuff, and it's easy to forget sometimes. Mitral stenosis. Rheumatic heart disease, late and highly specific sequelae of rheumatic fever. Opening snap. What do we think with opening snap? Well, we're thinking mitral stenosis. Heart murmur, congenital. So we have a congenital heart murmur, start thinking about mitral valve prolapse. Next page. This is a section of its own decent size as well, it looks like. Okay. Cyanotic heart disease, early. This could be an indication of tetralogy of Fallot, most common. D, transposition of great arteries. Persistent truncus arteriosus. Total anomalous pulmonary venous return. Tricuspid atresia, left to right shunts. Right to left shunts. So cyanotic heart disease, it could be a lot of things. So you have this, some kids born and you realize, oh wow, they're cyanotic, like they're really cyanotic, they're really blue. It could be a number of different things. Tetralogy of Fallot is the most common though, just for reference. Congenital heart disease, left to right shunt. What do we think? Most likely VSD, then ASD, then PDA. So most likely ventricular septal defect, then maybe atrial septal defect, then a patent ductus arteriosus, but most likely is VSD for a left to right shunt. Late cyanotic shunt, uncorrected left to right shunt becomes right to left. Late cyanotic shunt, uncorrected left to right shunt becomes right to left. So it's initially left to right, and then eventually becomes right to left. What is that going to be? Eisenmenger syndrome, caused by VSD, ASD, and PDA. That's classical Eisenmenger. Secondary hypertension. Renal vascular diseases, that is to say fibromuscular dysplasia, atherosclerotic renal artery stenosis. Primary hypoaldosteronism, or OSA. And I just want to confirm what OSA means in this context. Just I want to make sure exactly what they're talking about. Hypertension. OSA, I think, is obstructive sleep apnea. Okay. Again, these are associations for reference. Sites of atherosclerosis: abdominal aorta, then maybe coronary artery, then after that popliteal artery, then after that, carotid artery, and then after that, circle of Willis. So the most likely is abdominal aorta, is where you have this site of atherosclerosis. Most likely is abdominal aorta. Aortic aneurysm, thoracic. So if you have thoracic aortic aneurysm, what do we think with that? Marfan syndrome, cystic medial degeneration, tertiary syphilis, which is obliterative endarteritis of vasa vasorum. Next, an abdominal aortic aneurysm. What do we think? Atherosclerosis or tobacco use. So if it's a thoracic issue, we're thinking, oh, like Marfan syndrome or something, right? Or tertiary syphilis. Sure, okay. If it's okay, sure. Granted, that's true. But what about a abdominal aortic aneurysm? What do we think in that context? We're thinking tobacco use or atherosclerosis. So it's a little bit different in terms of what causes it. Now, aortic dissection. That's pretty serious. It's caused by hypertension. Most important risk factor is hypertension. Now we're going into something a little bit different. Irregular rhythm on EKG with no discrete P waves. What do we think? AFib, atrial fibrillation, associated with increased risk of emboli. Right heart failure due to a pulmonary cause. Think cor pulmonale. Heart valve and infective endocarditis. Think mitral is more likely than aortic or tricuspid. Injection use, but most likely mitral. If not that, then maybe aortic or tricuspid. And that is again from like an injection drug use, for example. Infective endocarditis presentation associated with bacteria. What are we thinking? Staph aureus, acute injection drug use, tricuspid valve. Then viridans, streptococci, subacute, dental procedure, or it could be strep galolyticus, which can cause colon cancer, by the way. Very weird, too. But it's kind of a strange little factoid. Yeah, it can cause colon cancer on top of that. Or a gram-negative HACEK, or a culture-negative Coxiella or Bartonella. But typically, when I hear infective endocarditis species, I'm thinking Staph aureus, I'm thinking viridans, streptococci, or I'm thinking strep galolyticus. Those three are kind of the big ones. And again, viridans, think about dental procedures. When you hear galolyticus, think about colon cancer. And when you hear Staph aureus, think about injection drug use. And I guess apparently tricuspid valve. Cardiac tumors in adults. Think about metastasis, myxoma, 75 to 80% in left atrium, ball valve. So that's for cardiac tumors in adults. Now, what about a cardiac primary tumor in children? What do we think? Rhabdomyoma associated with tuberous sclerosis. Next, hypercoagulability, endothelial damage, and blood stasis. Think Virchow triad, increased risk of thrombosis. Next, congenital adrenal hyperplasia, 21-hydroxylase deficiency. Next, hypopituitarism. What do we think? Pituitary adenoma, undersecretion due to mass effect. Congenital hypothyroidism, thyroid dysgenesis or dyshormonogenesis, or it could just be an iodine deficiency. Thyroid cancer, what do we think? Papillary carcinoma, RET/PTC rearrangements, BRAF mutations, childhood irradiation. Irradiation. Okay. What about hypoparathyroidism? What do we think? Accidental excision during thyroidectomy. Yeah, that's basically a pretty good one. Primary hyperparathyroidism. So we have a primary hyperparathyroidism. What do we think in that case? Primary hyperparathyroidism. Adenomas, hyperplasia. Okay, what about secondary hyperparathyroidism? Hypocalcemia of chronic kidney disease. Cushing syndrome, with basically increased cortisol. What do we think? exogenous glucocorticoids, so you're just giving yourself more glucocorticoids like a medication or something. Adrenocorticoadenoma, which secretes excess cortisol. ACTH secreting pituitary adenoma, Cushing's disease, right? Or a paraneoplastic due to ACTH secretion by tumors. So, there's a couple of, when we talk about Cushing's syndrome, it's kind of a broad topic. Could it be cortisol is high because you're just bringing it into your body, like you just have excess, exogenous glucocorticoids because you're just, introducing it? Could it be because you're just producing more from a tumor? Could it be because you just have high ACTH levels? It could be all the. It could be any of the above mentioned. Because Cushing's syndrome is a broad category referring to a high cortisol level. But what about Cushing's disease? That's a little bit more specific. Cushing's disease could be from a decreased ACT. It could have a decreased ACTH and decreased cortisol in high-dose dexamethasone suppression test, and increased ACTH and increased cortisol in a CRH stimulation test. And I just want to confirm specifically Cushing disease. Yeah, so basically Cushing's disease, Cushing's disease falls within the context of Cushing's syndrome, but Cushing's disease specifically is when you have excess ACTH. So when you have high ACTH causing your high cortisol, that's called Cushing disease. Primary hypoaldosteronism. Think about bilateral adrenal hyperplasia or adenoma, Conn syndrome. Again, that's CONN syndrome. Tumor of the adrenal medulla in children. Think about neuroblastoma, which is malignant. Now, tumor of the adrenal medulla in adults is pheochromocytoma, which is usually benign. Now, it doesn't mean you want to have a pheochromocytoma because you have all this sort of excess production of adrenaline, right? You don't really want that to be happening, but it's technically it is benign normally. But in children, neuroblastomas are, malignant. So think about that. Again, I might take a short break. Okay. Next section. Well, we're continuing with this particular section, to be fair. We're just next page, I should say. Refractory peptic ulcers and increased gastrin levels, even after the secretin test. Think about Zollinger-Ellison syndrome due to gastrin-secreting tumor of the duodenum or pancreas associated with MEN1 or MEN1. Esophageal cancer. Think about squamous cell carcinoma worldwide or adenocarcinoma in the United States. Acute gastric ulcer associated with CNS injury. Think about Cushing ulcer, increased vagal stimulation, leading to an increase in ACH, or acetylcholine, right? Leading to an increase in hydrogen ion production. Next, acute gastric ulcer associated with severe burns. Think curling ulcers, hypovolemia leading to mucosal ischemia. Next, chronic atrophic gastritis. Think about an increased risk of gastric cancers, pernicious anemia, if autoimmune. Bilateral ovarian metastases from gastric carcinoma. Think about the Krokenberg tumor, mucin-secreting signet ring cells. Next, alternating areas of transmural inflammation and normal colon. Think about skip lesions like you would see in Crohn's disease. If it's alternating between these transmural inflammation and it just looks like a normal colon in other places, that's probably Crohn's disease if it's going back and forth. Site of diverticulosis. Think about sigmoid colon. Sigmoid colon is where you have the diverticulosis typically. False pharyngoesophageal diverticulum. Think about Zenker diverticulum. Hepatocellular carcinoma. What do you think? HBV, positive or negative cirrhosis. Other causes of cirrhosis, HCV, alcoholic liver disease, specific carcinogens like aflatoxins. Now, with that being said, if you have a different viral hepatitis instead of HCV, HBV, I think you can still get HCC, you can still get hepatocellular carcinoma, but I guess more classically it is HBV and maybe HCV, and of course, like aflatoxins, alcoholic liver disease, etc. Inherited conjugated hyperbilirubinemia secondary to hepatocyte inability to secrete conjugated bilirubin in bile. Think Dubin-Johnson syndrome, black liver, Rotor syndrome, which is uncolored liver. So they have, they're both, inherited conjugated hyperbilirubinemia secondary to hepatocyte inability to secrete conjugated bilirubin in bile. Sure. But if it's colorless, think about Rotor syndrome, ROTOR syndrome. And if it's black liver, think about Dubin-Johnson syndrome. Now, what about this? Inherited benign unconjugated hyperbilirubinemia. What do we think? Gilbert syndrome. Inherited ATP7B mutation, copper buildup in the liver, brain, and cornea with Kaiser-Fletcher rings, right? And kidneys. What do we think? Wilson's disease. So I was saying, what they were saying here is that, if you have buildup of copper in the cornea, it will give off that presentation of Kaiser-Fletcher rings. That's spelled Kayserflischer rings. If you see a picture of it, you'll kind of like, oh yeah, that looks. You can look it up right now if you want to. It is interesting presentation, but if you have copper buildup in the body, like in the liver, the brain, the cornea, the kidneys, think Wilson's disease. Very unique in that sense. Multiple blood transfusions or hereditary HFE mutation can result in heart failure, bronze diabetes, and increased risk of hepatocellular carcinoma. What do we think? Hemochromatosis. Pancreatitis, acute. Think gallstones or alcohol. Pancreatitis chronic, if it's chronic pancreatitis, think about alcohol in adults or cystic fibrosis in children. Microcytic anemia. This is an iron, think about iron deficiency, thalassemia, lead poisoning, or sideroblastic anemia. Autosplenectomy, fibrosis and shrinkage, Howell-Jolly bodies. Think about sickle cell anemia, hemoglobin S. Next, inherited platelet disorder with GP1B deficiency. Think about Bernard-Soulier syndrome, decreased platelet to von Willebrand factor adhesion. So the platelet to von Willebrand factor adhesion between those two different things is going to decrease in the context of Bernard-Soulier syndrome. Next, inherited platelet disorder with G2B3A deficiency. This would be Glanzmann thrombasthenia with a decreased platelet to platelet aggregation and a defective platelet plug formation. Hereditary thrombophilia, commonly associated with recurrent pregnancy loss. This would be a factor V Leiden mutation, factor V Leiden, mutant factor V resistant to degradation. So basically, as far as I recall how that works, is that factor V is going to be regulated by protein C and protein S. I think technically it's an activated protein C. I need to look into that a little bit further. How does factor V Leiden mutation work? How does that work? It's resistant to activated protein C. So protein C normally, when it's activated, is able to kind of inhibit factor V in the coagulation pathway. And if it has a mutation, well, that prevents it from being able to be regulated correctly. And so you can get these sorts of issues with, again, a hereditary thrombophilia and a recurrent pregnancy loss. So not good. Disseminated intravascular coagulopathy. What do we think about? Which is DIC for reference. What do we think? What are we thinking about? Heat stroke, snakebite, sepsis, trauma, obstetric complications, acute pancreatitis, malignancy, nephrotic syndrome, transfusion. A lot of things can cause DIC. Common malignancy associated with non-infectious fever and bimodal age distribution. Hodgkin lymphoma. Type of Hodgkin lymphoma, which is the most common. Nodular sclerosis. T14:18. T14 semicolon here now, 18. What do we think? Follicular lymphoma, BCL2 activation, anti-apoptotic oncogene. Let me take a short break again, just a drink. Okay, we're back. T8 semicolon 14. You might think to yourself, I just said that. No, I said before T14 18. Now we're talking about T8 14. What do we think? Burkitt lymphoma, CMYC fusion, transcription factor oncogene. Again, Burkitt lymphoma is associated with EBV, Epstein-Barr virus. Type of non-Hodgkin lymphoma, most common in adults. Diffuse large B-cell lymphoma. Next, age ranges for patients with ALL, CLL, AML, CML. What are we thinking? ALL, child, CLL, adult, greater than 60. AML, adult, around the age of 65. And CML, adult, 45 to 85. So let me just make sure that I'm communicating exactly what all those things are. So let's talk about it right now. ALL is acute lymphoblastic leukemia. CLL is chronic lymphocytic leukemia. AML is acute myeloid leukemia. And CML is chronic myeloid leukemia. Okay. T922. T9 semicolon 22. Philadelphia chromosome, CML, BCR, ABL oncogene, tyrosine kinase activation, more rarely associated with ALL. Next, vertebral compression fracture. Think osteoporosis. HLA B27. What do we think? Psoriatic arthritis, ankylosing spondylitis. That's bamboo spine. IBD associated arthritis or reactive arthritis. Death in lupus. Death in SLE. What do we think? Renal disease, most common. Infections. Cardiovascular disease. Accelerated CAD. Yeah, so it could be those things. But most common is renal disease. Giant cell arteritis. Risk of ipsilateral blindness due to occlusion of ophthalmic artery associated with polymyalgia rheumatica. Next, recurrent inflammation/thrombosis of medium-sized vessels and extremities. Think Buerger disease, strongly associated, that's B-U-E-R-G-E-R. I haven't said that before, to be fair. It is the first time I've said it here. But B-U-E-R-G-E-R disease, strongly associated with tobacco smoking, Raynaud phenomenon. Next, benign vascular tumor of infancy. Infantile hemangioma grows rapidly, then involutes starting at age 1. Next, Herald patch, followed by scaly erythematous plaques in a Christmas tree distribution. Think pityriasis rosea. That's pityriasis, R-I-A-S-I-S, pityriasis rosea. Actinic keratosis. Think about precursor to squamous cell carcinoma. Cerebellar tonsillar herniation. Think about Chiari-1 malformation associated with the spinal cord cavitations, that is to say, syringomyelia. Next, bilateral mammillary body lesions with thiamine deficiency. Think about Wernicke-Korsakoff syndrome. Really, there's a Wernicke syndrome, there's a Korsakoff syndrome. It's kind of on a spectrum, but there is some differences between the two technically. Korsakoff is much worse. Epidural hematoma. Epidural hematoma, think about rupture of the middle meningeal artery, trauma, or biconvex lentiform shape. So there's the shape is basically this sort of this convex shape that you would see, and it is, I guess you could say it's lentiform if you want to, and it's going to be usually a rupture of the middle meningeal artery. What about a subdural hematoma? What do we think with that one? Rupture of the bridging veins, trauma, cerebral atrophy. It's crescent shaped. What about dementia? Dementia, Alzheimer's disease, vascular dementia, multiple infarcts, stepwise decline. So they're saying that if you have dementia, it could be Alzheimer's, it could be a vascular dementia. And typically when we talk about vascular dementia, we're talking about stepwise decline. I think it's easier just to remember that, I would remember that phrasing. I would look more into that in terms of what they were talking about in that context, because it's not always super clear. But I always have trouble kind of grasping what do they even mean in that context. But just look into it more, because there's a very good chance they might mention it on an exam, but they might not use the word stepwise decline. Next, demyelinating disease in young women. Think multiple sclerosis. Brain tumors in adults. Think about metastasis, glioblastoma, malignant, meningioma, and hemangioblastoma. Next, galactorrhea, amenorrhea. Think prolactinoma. Next, brain tumor, but in children. What do we think? Overall, pilocytic astrocytoma, which is benign. Infratentorial, we would think medulloblastoma, which is the most common malignant type. And for a supratentorial, think about craniopharyngioma, which is also malignant. What about this? Combined UMN and LMN degeneration. What do we think in that context? Of both UMN and LMN issues. What do we think? Amyotrophic lateral sclerosis. There's a more common name we think about for that, which is the acronym ALS. ALS is where you have upper motor neuron and lower motor neuron issues. Degeneration of dorsal column fibers. What do we think? Tabes dorsalis, which is related to tertiary syphilis. Subacute combined degeneration, which is related to a vitamin B12 deficiency. Dorsal columns, lateral cortex spinocerebellar tract affected. Now let's talk about this. Nephrotic syndrome in children. What would cause that? Minimal change disease. Now we're going on to this next page over here. Again, we're kind of more on the back end, to be fair. But this is the last page of this particular section. Then we transition into equations review, which is its own little thing. Let's talk about this. Kidney stone. What's a radiolucent kidney stone? What do we think? Uric acid. Kidney stone, but it's radio-opaque. What do we think about that? Calcium, most common. Struvite stone, which is from ammonium. Or cystine, faintly radio-opaque. Good to be aware of. Renal malignancy in males. What do we think? Renal cell carcinoma associated with tobacco smoking and VHL, which is von Hippel-Lindau. Von Hippel, like Hippel, and I think Lindau would be Lindau. Yeah. Clear cell subtype. Think about renal cell carcinoma associated with tobacco smoking and VHL. Clear cell subtype may present with paraneoplastic syndromes, EPO, renin, PTH, RP, and ACTH. Primary amenorrhea. What do we think? Turner syndrome, 45XO. There's no O chromosome. It just means that you're missing an X chromosome. So basically, someone who has Turner syndrome, they are female because they have no Y chromosome, right? They have no S or Y gene to cause them to be male. So they're female. And they have an X chromosome, good, sure, but they're missing another X chromosome. And so there's some issues afoot, essentially, with that. But typically how we write that is we write XO, which implies that they should have a second X chromosome, but they don't. Turner syndrome, 45XO. Again, normally people have 46 chromosomes, so they're just missing a chromosome. Turner syndrome 45XO or 45XO/46XX mosaic. And that's similar to some other conditions as well. You can have, for example, Down syndrome where you're mosaic for it, where you have Down syndrome, you have trisomy 21, you have 47 chromosomes, and you have a mosaicism where you have a normal genotype with 46 chromosomes, and they're mosaic, and as a consequence, they might technically have Down syndrome, but not be as severe as otherwise normal, like non-mosaic Down syndrome. In this case, you could have a similar situation where you might have a mosaic presentation of having some cells in your body being Turner syndrome, where you'd have the XO, but in other cells it might just be XX, like a normal non-Turner syndrome presentation. So that's mosaicism. You can have more than one genotype depending on what cells you're looking at, essentially. It's a little weird, but it does happen. Hypogonadotropic hypogonadism with anosmia. Anosmia referring to like a weak sense of smell. Hyposmia would be weak sense of smell. I guess it would be lack of sense. You can't smell anything. Anosmia. So you have hypogonadotropic hypogonadism with a lack of a sense of smell. What do we think? Kallmann syndrome. Kallmann syndrome. Kallmann syndrome. Neuron migration failure. Next, clear cell adenocarcinoma of the vagina. Think about DES exposure in utero. DES is a drug, and so that can be exposed in the utero when the mother is taking that at the time. Ovarian tumor, benign, bilateral. What do we think? Serous cyst adenoma. So ovarian tumor that's benign bilateral, think about serous cyst adenoma. What about an ovarian tumor that's malignant? What do we think in that case? Think about serous carcinoma. What about a benign tumor of the myometrium? Well, think leiomyoma, estrogen sensitive, not precancerous. Doesn't mean it's great. Doesn't mean you want to have it, but it's not precancerous. What about gynecologic malignancy, which is the most common? Endometrial carcinoma, most common in resource-rich countries, but cervical cancer in most common worldwide. So I imagine that endometrial cancer would be like if you live in a what do they call today a developed country, like Western Europe, North America, Japan, Korea, South Korea, I should say, Australia, New Zealand. You might have the most common thing would be endometrial cancer, but in other countries it would be cervical cancer, and that's for gynecologic malignancies that are the most common. Breast mass. What are we thinking? Don't answer that question. Fibrocystic change. When we talk about breast mass, think about fibrocystic change in premenopausal females and carcinoma in postmenopausal females. You say, well, why would there be a difference? Well, because the hormones are different, and so the consequences of the hormones are relevant. If you have a certain kind of hormonal profile when you're younger, that's going to lead to different kinds of physiological changes, which might mean that when you have when you have a fibrocystic change, it might just be normal. It might just be benign, right? It might not be a problem. But if you have it as a person who is after they've gone through menopause, that could be something that's more likely to be serious that you need to look into. Something to be aware of. Breast tumor, benign in young women. Think about fibroadenoma. Breast cancer. Think about invasive ductal carcinoma. Although there are other kinds of cancers, to be fair, of the breast. But think about invasive ductal carcinoma, just for reference. Invasive ductal carcinoma. Bloody nipple discharge. Think about intraductal papilloma, no palpable mass, invasive ductal carcinoma, hard palpable mass. Okay. Testicular torsion, what do we think? Seminoma. Think about seminoma for testicular torsion. Seminoma, testicular tumor. Testicular tumor, think about seminoma. It's a malignant, radiosensitive, increase in placental alkaline phosphate, PLAP. Bladder outlet obstruction in men, think about BPH. That's the very common one. That's benign prostatic hyperplasia. Pulmonary hypertension, idiopathic left heart disease, idiopathic left heart disease, lung disease / hypoxia, chronic thromboembolism, or is multifactorial. What about SIADH? It's a symptom of inappropriate ADH. So you have way too much ADH in the body, too much of this, I think it's vasopressin, too much of that going on. What's going on with that? What could cause that? What's associated with that? Think about small cell carcinoma of the lung. So small cell carcinoma of the lung, it can cause SIADH. Okay, so that actually concludes that particular section on the associations, called the key associations. Now we're in the last two sections, which are both admittedly relatively short, and these are going to be the equation review for the next one. So equation review, I'm going to go to that page now, and I don't know if this one will actually be in a proper order just because of the fact that, it should, I would imagine it would be. So these are the equations. Is it the same order? No, it is not. Wow, you really just can't win with this stuff, You would think, oh, well, this would be in the same order because, what do you call it? Let me see. Can I go to the volume and distribution. Where's volume and distribution? You think it would this would be the same because, why would it not? It's not maybe as focused on the alphabetical system in this case. It might be some more overlap, you could say. Right here, let's start with this page right here. Here we go. But it is a little bit different. So I'll try to accommodate to some degree, but probably not all that much. Volume of distribution. VD, and you can just look at it on the thing as well. Okay, VD equals amount of drug in the body divided by plasma drug concentration. So that's the volume of distribution. It's the amount of the drug in the body divided by the plasma drug concentration. Half-life. The half-life equation is T1/2 equals 0.7 times VD, which is volume of distribution, divided by CL, which is the drug clearance. So 0.7 times volume of distribution divided by drug clearance equals half-life. Now, drug clearance is the rate of elimination of the drug divided by the plasma concentration of that drug, which is also, you could call it VD times KE, which is the elimination constant. Now, the loading dose. Loading dose is LD. Loading dose equals the CP times the VD. Okay. CD over VD divided by F. So loading dose is CP times VD over F. Maintenance dose would be CP times the CL, which is the, what is it called again? That's a drug clearance. So CP times CL times, is that tau? Is that tau? I'm not sure. It'd be tau divided by F. Therapeutic index. This would be therapeutic index equals median toxic dose / median effective dose. So TD50 divided by ED50. So therapeutic index is basically what is the dose you would have that would cause it to be toxic, and just divide that by the dose you would need that would make it effective. Again, this is the median, so in 50% of cases. So what is the dose you would need to get toxicity in 50% of people, and then divide the number by the number of cases you would need to have for it to be effective in 50% of people, or to have an effect, I guess you could say. The effective dose. Odds ratio. Let me see if I can find this on the thing again. This is the next page for me. Odds ratio. I feel like mine's a little bit longer. Maybe not. Maybe the same or similar. I don't see odds ratio on here. Let's see. Oh, it's mentioned here. Here we go. Odds ratio for case control studies. Odds ratio, OR equals A over C divided by B over D, which equals AD divided by BC. Relative risk, RR equals A divided by A plus B all over C divided by C plus D. Attributable risk is AR equals A divided by A plus B all minus C divided by C plus D. Relative risk reduction, RRR equals ARC minus ART all divided by ARC. Absolute risk reduction is ARR, which equals C divided by C plus D minus A divided by A plus B. Now, number needed to treat is NNT equals 1 divided by ARR. Number needed to harm, NNH, equals 1 divided by AR. Likelihood ratio plus LR plus equals sensitivity divided by 1 minus specificity equals TP rate divided by FP rate. Likelihood ratio negative, right? This is going to be LR negative equals 1 minus sensitivity divided by 1 divided by specificity. And in both cases, by the way, the 1 minus is always a 1 minus something, but it's flipped, just for reference. Sensitivity is always in the numerator, and the specificity is always in the denominator, but where the 1 minus portion is going to be flipped depending whether it's a positive or negative likelihood ratio, just for reference. You know, I'm kind of lost in this section. I might have to review this later on, but I remember that part when we're being taught some of the statistical stuff related to this stuff, you know. But anyway, Fn rate divided by Tn rate. Sensitivity. Sensitivity is TP, true positive, divided by true positive plus false negative. So basically, sensitivity is, if they have it, how likely am I to actually find that they have it? Specificity is Tn, or true negative, divided by true negative plus false positive. That is to say, if they do not have it, how likely am I to figure out that they don't have it? Post-predictive value. PPV equals TP, true positive, divided by true positive plus false positive. So the idea with this is to say, if they tested positive, how likely are they to actually have it? Negative predictive value, NPV, equals true negative divided by true negative plus false negative. That is to say, if they tested negative for it, how likely are they to really not have it? Very important stuff, by the way. We're talking about, I guess, epidemiology or something like that. If you have, because this is a big issue when talking about the HIV or AIDS crisis and stuff like that. If you had people who would, hypothetically, just give us an example, people who were getting HIV tested and they were not necessarily at risk for having HIV, if you have a large enough population of people who are getting tested for HIV or any other disease for that matter, and there's really no serious risk for them having it in the first place, there's going to be some minority of people who are who are testing positive when they really just don't have it. It's just a consequence of how these things work. There's errors that exist. There's imperfections and inaccuracy. And they think, oh, well, I have HIV or I have whatever it might be. And they just don't. They just don't have it. And there was no risk for them having it, you know. And that's part of the reason why we want to be, you know, careful when we administer tests to people, because there is a possibility of a false positive or a false negative. And so we can't necessarily perfectly rely on tests to ensure accuracy in all circumstances, unfortunately. Cardiac output, okay? CO equals the rate of O2 consumption divided by the arterial O2 content minus venous O2 content. CO also equals stroke volume times heart rate. That's what I typically think about. Mean arterial pressure. MAP equals the cardiac output times the total peripheral resistance. MAP at resting heart rate equals 2/3 of the DBP plus 1/3 of the SBP, which is this is diastolic blood pressure plus the systolic blood pressure, equals DBP plus 1/3 of the PP. Stroke volume, SV equals EDV minus ESV. Ejection fraction, EF, is equivalent to SV over EDV, which is equal to EDV minus ESV all over EDV. Resistance is equivalent to or equals driving pressure delta P divided by flow, which is Q. which is also equivalent to viscosity times length divided by pi r4. Okay. Capillary fluid exchange. JV equals net fluid flow equals KF multiplied by PC minus PI. It was all brackets, so KF bracket parentheses PC minus PI parentheses minus sigma parentheses pi C minus pi I parentheses bracket. I would just look at this section, try to figure out what they're even talking about in the first place. I would almost, if I were you, I would almost skip to the next section. Reticulocyte production index. RPI equals percent reticulocytes times actual HCT divided by normal HCT, which is hematocrit. Actual hematocrit divided by normal hematocrit divided by maturation time. Renal clearance, CX equals UXV divided by PX. Glomerular, so CX equals UX times V divided by PX. Glomerular filtration rate, C inulin equals GFR equals U inulin times V divided by PX. P inulin, okay. Which also equals KF bracket PGC minus PBS parentheses minus parentheses pi GC minus pi BS parentheses bracket. Effective renal plasma flow. ERPF equals UPAH times V divided by PPAH equals CPAH. Filtration fraction FF equals GFR divided by RPF. Next, fractional excretion of sodium is iron FeNa equals V times UNa divided by GFR times PNa equals, which is equal to PCR times UNA divided by UCR times PNA. I assume that the Na is sodium and the Cr is creatinine or something like that. It's talking about the fractional excretion rate, or fractional excretion of sodium, which I guess creatinine is like a reference point because creatinine is very relevant for that kind of stuff. Henderson-Hasselbalch equation for extracellular pH. pH equals 6.1. Let me see if I can find this again. Is this it? Yeah, here we go. Here we go. So pH equals 6.1 plus log bicarb divided by 0.03 PCO2. Winter's formula for predicted respiratory compensation for simple metabolic acidosis means PCO2 equals 1.5 times bicarb plus 8 plus or minus 2. That equation you probably will need to know at some point. It might only get you 1 or 2 questions, but, that's still 1 or 2 questions. The anion gap. Sodium minus, in parentheses, chloride plus bicarb. So basically, anion gap is sodium minus chlorine minus bicarb. It's those cation, sodium, minus those anions, chloride and bicarb. Next, physiological dead space. VD equals VT times PaCO2 minus PeCO2 divided by, both of those are divided by PaCO2. Next, pulmonary vascular resistance, PVR, is P pulmonary artery minus P left atrium divided by cardiac output. Now, alveolar gas equation is PaO2 equals PiO2 minus PaCO2 divided by RQ equals 150 mmHg, little a, minus PaCO2 divided by 0.8. Again, how does that translate into, how do you use that? Not entirely sure. Some of those things I know, a lot of those things I some of them I know about, but only vaguely from before. And some of those things I really couldn't tell you what they're talking about. So, good luck with that. We're going to go to the next section, but I'm going to take a little bit of a break. Okay, break is over, and this is our last section. It is not particularly long. It's like a little bit over a page, I think. It's this page here and the next page, but they're not both partial. And it is all about easily confused medications. So these are going to be Let me just go to it right now. If they have it in this PDF as well, I would assume they do, but I don't. Nope. I think what happened is that this section on easily confused medications became the medication thing they talked about before. So they replaced one section of a different section. So we need to get rid of this section on medications and replace it with this different medication section. I think that's what happened. So I don't know if I actually have it. I have key associations, sure. Do I have... I don't know if I have it or not. I don't think I do. Let me just check one more time. But regardless, they look like they have a pretty good classical relevant treatment section. That's cool. So that's probably what they had instead. Honestly, I might have to read this PDF about this section in particular, but instead I'll read you this section that I have in my own textbook right here. Again, this is the 2025 edition, so we'll get into it. Easily confused medications. Amiloride, clinical use and mechanism. So, okay, sure. So this is like, what does amiloride do? Amiloride, so drug, clinical use / mechanism of action. So what does amiloride do? Amiloride is for hypertension, potassium-sparing diuretic, blocks epithelial sodium channel in the late distal convoluted tubule and collecting duct. Amiodarone, ventricular arrhythmia, atrial fibrillation, supraventricular tachycardia, potassium channel blocker, class 3 antiarrhythmic. Amlodipine, hypertension, angina, dihydropyridine, calcium channel blocker. Benstropine, Parkinson's disease, extrapyramidal symptoms, cholinergic antagonist. Bromocriptine, Parkinson's disease, hyperprolactinemia, dopamine agonist, rarely used. Buspirone, generalized anxiety disorder, partial 5-HT1A and receptor agonist. Bupropion, depression, smoking cessation, norepinephrine dopamine reuptake inhibitor, which is, I think it's called I would assume it's norepinephrine, so N, dopamine D, reuptake inhibitor RI, so would that be ND or I? I'm not quite sure what you'd call that. Because we usually think about SSRIs and all the other kind of thing. I don't know if this would be technically its own little acronym or not. Cimetidine, gastric peptic ulcer, H2 receptor antagonist. Also causes gynecomastia in men, so just watch out for that. Cetirizine, allergy, second generation H1 receptor antagonist. Chloramphenicol, antibiotic, blocks the 50S subunit. Chlorodiazepoxide, ethanol withdrawal, alcohol withdrawal, right? Increased frequency of chloride channel opening in GABAergic neuron membranes, long-acting benzodiazepine. Now, I'm going to say a little bit of an aside right here. They like to say, these are easily confused because the names are similar. Well, unfortunately, by putting the names together, now I'm confusing them in a way that I would not otherwise, perhaps, potentially. Now, I would say that in the context of this kind of stuff, that one of the ways you can help remember these things, like which one is which, what does it do, is the names of them kind of indicate what drug class they might be. So when you say amlodipine, nifedipine, that kind of thing, that is a dihydropyridine calcium channel blocker. When you have something like lisinopril, ramipril, those are going to be ACE inhibitors. But what about simvastatin? You could just think about the names of it. What is it called? What does that imply? What drug class are they going to be implied? It's usually at the beginning of the word. It's usually the end of the word that gives you an indication. So what about this? Chlorpromazine. Think about schizophrenia, typical antipsychotic, D2 receptor blockade. Chlorpropamide is for diabetes, first generation sulfonylurea. You probably will not necessarily encounter that on your exam though. Chlorpheniramine, which is an allergy, first generation H1 receptor antagonist. Again, this is like Phenyramine, what do you think? Let's like diphenhydramine, like what do you think with that, right? It's going to be an if for the allergies. So these are going to be H1 receptor antagonists. Chlorothalidone, that's for hypertension and edema. Inhibits the sodium and chloride reabsorption in the distal convoluted tubule, the DCT. Thiazide diuretic. So, you think about hydrochlorothiazide, but actually chlorothalidone is also another thiazide diuretic. Clozapine. Clozapine for schizophrenia, atypical antipsychotic, D2 receptor partial agonist. Clomipramine. Clomipramine is for depression, anxiety, chronic pain, tricyclic antidepressant. Final page. Ooh, cool. Okay. So, clomiphene, infertility due to anovulation, selective estrogen receptor modulator in hypothalamus. Again, these are the things that it helps clinically used for. What is it used for? Oh, okay, it's used for infertility. Clonidine, hypertensive urgency, ADHD, or alpha-2 receptor, is an alpha-2 receptor antagonist. Or agonist, alpha-2 receptor agonist. Clonidine. Doxepin. Doxepin is for depression, anxiety, bipolar disorder. It's a tricyclic antidepressant. Doxazocin for BPH, hypertension, alpha-1 receptor antagonist. So think also about like prazosin, that kind of thing. Those things are going to be, they're alpha-1 receptor antagonists. Eplerenone, hypertension, potassium-sparing diuretic, selective mineralocorticoid receptor antagonist. Propafenone, ventricular arrhythmia, paroxysmal atrial fibrillation / flutter, or supraventricular tachycardia, sodium channel blocker, class 1C antiarrhythmic. Fluoxetine depression, selective serotonin reuptake inhibitor, which is an SSRI. So fluoxetine is an SSRI for depression. Flufenazine is for schizophrenia, typical antipsychotic, D2 receptor antagonist. Mifepristone, pregnancy terminate, it causes abortions, okay. Mifepristone, it's to induce an abortion. Pregnancy termination, like, okay, what do we mean by that? Okay, can we just be blunt about it? We don't be, that's what it is. Okay, that's what they do. They kill a kid. That's what they're doing with that kind of stuff. Unfortunately, mifepristone, progesterone receptor antagonist. Misoprostol, used with mifepristone for pregnancy again, it's used for abortion. Misoprostol, again, used for an abortion. It's a synthetic PGE1 analog. Now, FYI, I am disavow, whatever, that kind of thing, sure. But it's in the textbook. Unfortunately, people in the United States do those kinds of things to a degree which is quite disturbing, unfortunately. Naloxone, opioid overdose, opioid receptor antagonist. Not to say that doesn't happen to the rest of the world as well, just, obviously, it's in my own neck of the woods, unfortunately. Naloxone, opioid overdose, opioid receptor antagonist. Naltrexone, alcohol and opioid use disorder, opioid receptor antagonist. Nitroprusside, hypertensive emergency, increase in cyclic GMP and nitrous oxide, of course. Nitroglycerin, it's used for angina, of course, right? Increase in cyclic GMP and nitrous oxide. Increase in cyclic GMP and NO. Omeprazole, right? Omeprazole is used for GERD. It inhibits the hydrogen potassium ATPase in parietal cells. Another way to say omeprazole is it's a proton pump inhibitor, right? What about ketoconazole? Ketoconazole is an antifungal, inhibits fungal sterol synthesis. And they don't mention here, but ketoconazole also has an impact on testosterone synthesis, which is kind of relevant, but they don't mention it here. Aripiprazole is for schizophrenia, atypical antipsychotic, D2 partial agonist. I want to go back to anastrozole for a little bit moment. Anastrozole is an azole antifungal, for reference. So there's a couple different antifungals, like I think isofluconazole is one of them as well, and I think posaconazole, something like that. Those are antifungals. They have the word azole at the end because they're all part of the same class. That does not mean, though, that everything that has an azole at the end of it is an azole antifungal. It could be, but it might also be something else. So, like, for example, omeprazole obviously is not an antifungal. Actually, give me a moment briefly for me, please. Um, okay. I think that was a bit of an unfortunate timing for a phone call, but where was I? I think, yeah, we're talking about omeprazole. Omeprazole, proton pump inhibitor, ketoconazole, it's part of the azole antifungal class. So a lot of things that have azole at the end are antifungals. So ketoconazole, for example, isofluconazole. But not everything that has an azole at the end is, in fact, part of that antifungal drug class. It could be something else. Aripiprazole is for schizophrenia, atypical antipsychotic D2 partial agonist. Obviously, that's not part of that same class. Anastrozole, this is for ER positive breast cancer in postmenopausal women, aromatase inhibitor. Rifaximin, this is for hepatic encephalopathy, inhibits DNA-dependent RNA polymerase, decreasing ammoniogenic bacteria. Rifampin, anti-tuberculosis drug / antimicrobial, inhibits the DNA-dependent RNA polymerase. Sertraline, depression, PTSD, selective serotonin reuptake inhibitor. So that's an SSRI. Selegiline, Parkinson's disease, it's a MAL-B inhibitor. Trazodone, which is for insomnia, blocks the 5-HT2, alpha-1 adrenergic, and H1 receptors. Also weakly inhibits the 5-HT reuptake. Tramadol, chronic pain, weak opioid agonist. Varenicline, smoking cessation, nicotinic acetylcholine receptor partial agonist. And venlafaxine. Venlafaxine is for depression, diabetic neuropathy. It is a SNRI. It's a serotonin norepinephrine reuptake inhibitor. Okay? And that concludes our chapter for the rapid review section of our Step 1 textbook for the first aid for the USMLE Step 1 textbook for the 2025 edition. Apologies for any sort of interruptions or anything else that would necessarily inhibit perhaps or frustrate the viewer at home. But if you listened to this and got this far, well, thank you for listening, and hopefully this was of some utility to you. Thank you, and goodbye.